Okay, 8 o'clock. Can we start?
Yeah, get started.
There are only few participants. I think they will join slowly. Okay, because of the season 2, only the final years and some of the second years are joining. There are no first years, and we have only 14 students from Kerala. And with faculty, it is 20, and we hope Professor Jayanti and the students from Chennai also will join us soon. So good evening and welcome to the ISG Kerala chapter clinics. We have today with us Professor Ismail CR. He is a senior consultant of Medicine. He was earlier with Amrita and he was the professor of gastroenterology there. And Professor Ismail has taken a couple of cases earlier. And along with Dr. Ismail, we have Dr. Ramesh, Associate Professor of Gastroenterology at Pushpagiri Medical College and Hospitals. And Dr. Ramesh also taught you along with Professor Vinay Kumar earlier. Both of the faculty are very well-known clinicians and they are well-known for their astute clinical skills as well as research interest as well as teaching interest. And the presenter is Dr. Binila Jose from Pushpagiri Hospitals, and she will be presenting the case, and she will be analyzing it. And we can also ask other discussants, Dr. Dheeraj, Dr. Harish from Global Hospital. We can interrupt Dr. Binila's presentation and ask in between, and also others like Dr. Dheeraj and Dr. Harish also. And the planning of investigation and management part will be discussed by Dr. Dheeraj and Dr. Dheeraj, and subsequently, if we have time, Dr. Harish also. Okay. Welcome, Jayanti ma'am. With these words, we will begin today's clinic. Dr. Binila, please upload your slides. And the house rules are, when question is asked, the question will first go to the discussant. Then, of course, if the faculty specifically name anybody, they can answer. And if you have any doubts regarding the discussion, you can put it in the chat box. But if you give an answer prior to the answer being given by the discussant, it will be a little disappointing to us. So if you have additional points, you can put it in the chat box and raise any questions. We'll be happy to discuss if we have time. Over to Professor Ismail and Professor Dr. Ramesh.
Thank you, sir. Binila, you can start.
Good evening, sir. I am presenting case of a 65-year-old gentleman from Tiruvalla who is a retired security staff. History reported by self and
one more interruption, dear faculty. This is a pure teaching clinics and not exam mode. Okay, pure teaching clinics. Dr. Binila, continue.
Yes, sir. A 65-year-old gentleman from Tiruvalla, a retired security staff, and history is reported by self and has got a good reliability. He was presented to us with complaints of increased frequency of stools for the last 2 months, blood mixed with stool for the last 2 months. History of presenting illness. He was apparently normal 2 months back when he started having complaints of increased frequency of stools. That is 8 to 10 episodes of semi-form stools, that is Bristol type 6 per day, is small in volume and is mixed with blood and mucus. The blood and mucus is present in almost all stools. The frequency of stools are painless and is continuous over the last 2 months. The stools are non-foul smelling. He also gives history of nocturnal symptoms, that is 1 to 2 times loose stools at night time. There is no history of any tenesmus, urgency, no history suggestive of steatorrhea. There is no relation to food intake or there is no improvement of this frequency of stools on fasting. He also gives history of loss of weight of about 6 kilograms in last 2 months. He also gives history of anorexia. There is no history of any constipation, abdominal pain, abdominal distension, No history of any perineal swelling, perineal pain, or perineal discharge. No history of any borborygmy or any history of food allergies. No history of nausea, vomiting, headache, or any upper GI symptoms or dyspepsia. No history of any joint pain or swellings. There is no history of redness of eyes, oral ulcers, or skin rashes. There is no history of any fever, cough, breathlessness, night sweats, pruritus, or jaundice. No history of any edema, paresthesia, visual blurring, burning sensation in the tongue, or loss of taste or inborn pains. There is no history of giddiness, palpitation, heat intolerance, tremors of hands, or any neck swellings.
Can we just go to that history and discuss why all these questions were asked?
Oh, okay, ma'am. The duration, it's 2 months. So it's a chronic diarrhea. That is more than 4 weeks diarrhea. So it's a chronic diarrhea.
Hold on.
And
Hold
then,
on.
ma'am?
Just please hold on.
Okay.
Next slide.
Madam,
Just go to the next slide, yeah.
next slide.
Yeah. Yeah, now can you just go through some of these no histories and why you asked. This patient has come to you in the OP, okay?
Yes, ma'am.
So what are the things that you'll ask, and would you ask all these questions that you said no history, no history? Can you just highlight?
Yes, ma'am. I asked history of constipation, abdominal pain, and abdominal distension because if there is any bowel obstruction.
1 minute. Why did you ask for history of steatorrhea in this patient?
To differentiate whether it's a small bowel diarrhea or large bowel diarrhea, and if there is any malabsorption, ma'am.
Dr. Benila, your second complaint which you mentioned was the blood and mucus.
Blood and mucus in stool, sir.
So what does it denote? So it is a glaring history which is just staring at you.
Patient comes to you in the OP as blood and mucus diarrhea. Will you ask in the OP, do you have steatorrhea? I'm just asking a very simple question.
So, ma'am, blood and mucus is more common in large bowel diarrhea.
I'm asking the reasons. This patient has come to you, he's coming to you walking into the outpatient clinic. He says, I'm passing so many times and every time it's mixed with blood and mucus.
Yes, ma'am.
In this context, would you ask for history of steatorrhea and waste your time that are you passing bulky stool, foul smelling stool? Will you ask that question at all? See, I'm telling Dr. VT, that's what he said. No, this is practice oriented. This is not exam oriented, and even in exam, will you waste time asking for steatorrhea? Dr. Ismail, I think let us just get them right, in the right perspective, so that there are so many questions of borborygmy, food allergy. I mean, will you really ask all these questions in the outpatient clinic? What is the first thing that crosses your mind? I would just say that his bowel movement was once per day, normal color and consistency until the month of August or the month of July. And it was normal, he's doing well. When he noticed a change in the bowel pattern, that's what he could highlight. And what he's noticed is change in frequency, change in the consistency, change in the character. That's all that you need to ask. Would you ask for history of borborygmy, abdominal distension, melena in this patient?
Ma'am,
1 minute. Nausea, vomiting, headache. What is crossing your mind when you ask nausea, vomiting, headache, or dyspepsia?
Ma'am, one of my first possibility is colorectal malignancy. So whether to rule out any metastasis to brain.
Metastasis to brain, no? Nausea, vomiting, you'll ask with dyspepsia and headache in a patient with CA rectum.
Upper GI.
You'll ask for symptoms in upper GI. This patient's come to you in the clinic. Patient is already getting blood and mucus. It's all just a short case. This is nothing a long case at all.
Okay, ma'am.
Just remember, whatever you're presenting now is just what is practice oriented, what you would see in an outpatient clinic. That's all that you're asking.
Okay.
Swelling, redness of eye, that is okay. But other things, no, paresthesia, visual blurring, burning sensation, loss of taste, bone pain. I think Dr. BT, Dr. Ismail, I think please just get this right. This aspect of the history taking is very important.
Yeah, probably she might have started like an exam case. That's why she might have gone through all these.
Even in the exam, you cannot say all these negative points in the exam. That means your mind is running wild.
Vinila, when such questions are asked, you should have some idea about answering these questions. You could have answered that I just want to, even though it is a glaring blood and mucus in stools, there can be conditions where the large bowel as well as the small bowel is involved. So you should have some answers to that. So
Okay, sir.
why you are asking such questions, to know whether along with large bowel, whether the small bowel are also involved.
Okay, sir.
Okay. And as Madam said, when you ask for negative histories, you should also try to convey what is in your mind when you ask such history. For example, history of joint pain, swelling, redness of eyes. I think you are looking for extra-intestinal manifestations.
Extra-intestinal
So-
manifestations, sir.
So that it should not be just no, as Madam has said,
Okay,
all
sir.
negative history. You should
Okay, sir.
bringing more positive history.
Okay.
And moreover, when you say blood in stools, you should also quantify the blood. You should also say about the color of the blood. It can be bright red blood, or it can be altered blood. It can be clots. So you should quantify as well as visual. What was the visual impression to the patient when he saw the blood, or was it just some drops of blood? So that is more important than all this history which you have given
Okay,
to rule
sir.
out a small bowel disease.
Okay, sir.
And
It's
mention whether that anemia had an effect of fatigue, asthenia, listlessness, requiring blood transfusion. This is what you have to focus on.
Okay, ma'am.
Because his main symptoms was bleeding per rectum. So
Yes, sir.
Symptom
there
related
is-
to anemia, like
There is no
expressional
giddiness,
dyspnea.
palpitation, fatigue, etc., sir.
Why would you ask all this giddiness, palpitation, heat intolerance?
To quantify the blood loss.
Blood loss,
no, that is what
heat
that is what we were discussing. Actually, when you say giddiness, palpitation, I was thinking more in terms of thyrotoxicosis.
intolerance.
Because
I thought of carcinoid.
so basically, you should, when you say the negative history, you should also say why you are asked for it or what was in your mind when you asked such history.
Okay, sir.
Tremors of hands or neck. What is this tremors of neck? What is tremors?
Tremors of hands or neck swelling, ma'am. Neck swelling means to rule out thyrotoxicosis.
Patient would have thyrotoxicosis by any stretch of imagination?
Okay, Dr. Ramesh wanted to tell something.
Rather than this type of questions, you should ask the history suggestive of anemia or chronic blood loss, like exertional dyspnea, because patient is presented with the 2 months bleeding. So anything that is contributing to severity of bleeding, because assessing the severity of loose motion and blood bleeding per rectum also need to be included in history taking.
Okay, sir.
Dr. Benila, what I want to suggest is that as an undergraduate MBBS student, we can say all this no, which may be disconnected slightly. But as a postgraduate that you're doing gastroenterology, that means your second post-graduation, your no's has to be well qualified, and it cannot be a random no. And again, even the grouping, for example, the last time this giddiness, palpitation, you are just jumped to heat intolerance and tremors of hand, etc. Okay, so that means the flow, we can immediately assess your flow thought is not properly in the right direction. Okay,
Okay, sir.
now when you say no, you must actually have a list of differential diagnoses in your mind, and then you are trying to get extra points, positive or negative points for that differential diagnosis.
Okay, sir.
Okay, so it should not be just every GIT symptom starting from mouth to anus, you don't have to ask. It
Okay,
should
sir.
be pertaining to the case. For example, this patient has altered bowel habits and blood and mucus, not even bleeding PR, blood and mucus. It's not frank bleeding PR, blood and mucus. So this is two sets of symptoms. We want to know about the details of the altered bowel habits. We want to know the details of the blood and mucus. And because blood was there are conditions which can produce focal bleeding prior to the onset of overt symptoms. So you may ask for symptoms of anemia current, symptoms of anemia preceding. Okay,
Okay.
and other relevant things. And if there was abdominal pain which was significant, you could ask for other like to qualify it for small bowel pain or large bowel pain like that. Okay, so abdominal pain is not forthcoming in your history.
Okay.
Okay, the absence of abdominal pain, abdominal distension, vomiting, then going for asking for borborygmy is also it will not be accepted. Okay, so every negative blindly will not be accepted. You must be able to tell, as Dr. Ismail said, you must be able to, for example, if you said about small bowel diarrhea, that is because you thought of a differential diarrhea produce small intestinal and largest. You must be able to defend as well. Okay, so That was a good point Ismail pointed out.
Okay, sir.
Okay, so you must be able to define it like that.
Okay, sir.
We don't have to straight away jump to any particular diagnosis. We can think of a list of differential diagnosis and see whether other parts of the bowel or other part of the body can be affected due to these differential diagnosis, and then look for yes or no. Okay,
sir.
so it must
Okay,
not be a blind yes or no.
Okay, sir.
Okay,
And
so
even when you say the history, for example, you have said no history of tenesmus urgency, which are basically distal large bowel symptoms.
Yes,
And the next sentence you are saying no history of suggestive steatorrhea. So these are contradicting each other. If you want to bring out small bowel, bring all the symptoms of small bowel together rather than jumble up the symptoms.
Okay, sir.
that's right. The flow of thought. Your flow of thought can be easily inferred by the examiner or the faculty. Okay, whether you are thinking sensibly towards a particular thing or whether you are just adding up no and yes at random fashion. Okay, so at the moment we will consider it was a random fashion. Okay, so these no or yes should be well qualified. It should be well thought out. Okay, so that will be the learning point for today. No's and yes must be pertaining to the case and pertaining to the symptom. Okay, over to you to continue. You want any faculty? You want any further clarification?
History of digital evacuation is more important, no?
Yes.
Change in caliber of stool. These are the things that we want to know. Change in caliber of stool will almost point out that it is in the rectum. So just focus your attention. Moment say blood and mucus, it's ulcerated pathology. No, that's how I would describe. And moment I say it's ulcerated, I just want to know, is it in the descending colon? It's definitely not in the right side colon, right?
No. Yes, ma'am.
Likely. It's more of the rectum or sigmoid, somewhere there, somewhere around. And then just say what all can happen locally. So it can ulcerate, you can get blood loss, you can get fatigue. What can happen proximally? Sometimes you may get spurious diarrhea, you may have change in caliber of stool. And what can happen distally? You may have, again, constipation, there may be distal evacuation. These are the ways you have to focus.
Okay.
And other important thing, just remember one important thing, this I learned from Dr. Vinay Kumar. This, this weight loss, you think it has come simultaneously with the change in bowel pattern? Is it possible? This is something that Sir has taught, and I always remember this. Larger the lumen, weight loss and anorexia will come on much later. Say stomach will present more as anorexia and weight loss, and local symptoms of obstruction will come on much later. Suppose you have an esophageal pathology or a colorectal pathology, symptoms will come on first. Loss of an appetite, weight will come on much later. Simple dictum, and I appreciate that comment that I learned from him. So you cannot have, it is just not possible that he has a weight loss along with the symptoms of blood and mucus. Impossible. It's just not possible. Just remember this, smaller the lumen, symptoms manifest first, anorexia, weight loss will come on much later. Wider the lumen, say a person with, say, stomach or patient with colonic malignancy, say transverse colon cecum, they'll present more as anorexia, weight loss, and anemia, etc. will come on much later. I'll tell you, I mean, I'm little blunt or not, but in the exam, they'll say, Doctor, how many cases you've seen in the outpatient blood and mucus diarrhea? No? That will be the first comment. This will be the first comment. And what happens in corporate hospitals is that students are not allowed to see cases in the outpatient. This is exactly what happens. So they're not exposed to OP cases. You people see at the level of admission. Admission. So they start by no history. Continue.
Dr. Manila, did you understand the significance of that question, a digital evacuation?
Sorry, sir.
Okay. So the patient with SRV can present with
bloody diarrhea.
Sometimes copious mucus and blood also may be there. Okay, good.
So that you can also add the history of you were say anemia and all, the bowel symptoms, or does he have any altered bowel habits apart from these symptoms before the onset of these symptoms, like whether he was constipated before, which has changed recently, or
so he passed 1 to 2 times normal consistency stools, Bristol 3 to 4 prior to this 2 months. Sir.
Do you show the chart or you just take the history of Bristol stools?
I asked the consistency and
then how will you grade that? How will you type it?
I asked whether it's watery or it's having some solid.
So and water itself can be 6 and 7, can be watery. So how do you differentiate it? Historically, unless you show the chart.
7 means there is no salt compounds. 6 having solid compounds and ragged edges with the soft consistency. Sir.
So what about 3, 4, 5? How will you differentiate historically if you are not showing the chart?
Ideally,
So it is better not to use such terms when you take history if you're not showing the chart.
Okay, sir.
Bristol chart, then only we can actually say that it is correct, no?
Okay,
Because
sir.
patient will not have even heard of Bristol chart. So then he may imagine so many things and tell. If you show Bristol chart and say a patient points out the particular category, okay, you can say that it is. Even sometimes I will cross check, because this is the first time somebody is seeing it, and they will be also confused as to what to select. Okay, so you have to explain very well and identify from this which is the most common type which you find most frequently. Okay.
Okay.
There are some questions which one is what is the cutoff for large bowel and small bowel diarrhea? This is one question which was discussed during one of the ISG master class and later with us also. Actually, if you look at your textbook, there is no clear-cut cutoff with the volume. It is said that if the patient has features of excessive water loss. Am I not correct, ma'am? That means thirst, diminished urine output, that means excess thirst and diminished urine output suggests that there is significant water loss.
Exactly, it's more symptom related rather than the quantification.
Okay, this quantification of more than 1 liter or 1 kilogram, etc., is only for research purpose, not for ordinary clinical purpose. That is what I understand. Only in one vague test, there is a mention that if the approximate volume is more than 1 liter, you may call it large volume, and if it is less than 1 liter, you call it. But I didn't find any reference for that in any other textbooks. Okay. Then there was a question of how will you assess weight loss according? How will you interpret anorexia and weight loss according to bowel lumen? This is Jayanti ma'am said. Ma'am, can you just highlight that once more for the benefit of all?
Yeah, so it is like this. I learned it from sir only. If a person has CA stomach, antral growth, he'll first present with anorexia and weight loss because it's a wide lumen, no? So the symptoms will manifest much later. Like gastric outlet obstruction will manifest 2-3 months after the anorexia and weight loss because the growth is occurring slowly and steadily it's increasing. Suppose you have a CA of the esophagus, carcinoma of the esophagus. Moment the critical lumen diameter becomes less, the first presentation will be dysphagia. Weight loss and loss of appetite will not be there. No, it will be very little. He keeps on changing his diet habit, and so weight loss and loss of appetite will be reduced. Weight loss may be there, but loss of appetite takes on much later. He feels like eating, but he's not able to eat. Likewise, CA rectum will present more as symptoms, and weight loss and all will come on much later.
Anorexia as a manifestation of colonic disease or colonic neoplasm is, I would say, only in advanced cases, not in the early cases. Okay. If anorexia is the dominant manifestation, think of pancreas, think of stomach.
Exactly.
That's the general rule. And if the lesion is in the E junction or exactly in the pyloric region, they will present with a different symptom, and they may not even have anorexia. They may not even have. Okay. Okay, then there are no further questions. Can we proceed?
Yeah, you can proceed.
Past history. He's a non-case of type 2 diabetes, diagnosed 5 years back, and is on metformin 500 milligram once daily, and his blood sugars are in good control. He also gives history of dyslipidemia and is on atorvastatin 10 mg at night time. There is no history of any hypertension, asthma, pulmonary tuberculosis, or any malignant disease, no coronary artery disease, liver or kidney disease in the past. There is no history of any surgeries, no history of any radiation, no history of any recent hospitalization or any blood transfusion. Personal history. He denies the use of alcohol or he's not a smoker. He consumes a non-vegetarian diet with approximately calorie intake of 1,800 kilocalorie per day. His sleep is interrupted due to nocturnal symptoms. Appetite is reduced. Bladder habits were normal. There is no history of any high-risk behavior.
How do you assess the calorie intake What is
Sir,
the
daily,
what is the guideline you follow? Patient, an ordinary person from Kerala, may be eating 2-3 idlis in the morning, or upma or puttu, and then lunch, the usual lunch, and for evening supper, you may be either eating rice or chapati or some other thing. Okay, so this is what he will say, and he will say either I am vegetarian or I am eating vegetables and fish or meat, whatever it is, mixed diet. Okay, so how will you exactly quantify it as 1,800 calories? What is the
average daily recall, sir. Average.
Pardon?
Average of daily recall, sir.
Okay, you did daily dietary recall. That is what you do. Okay.
Yes, sir.
But how did you convert it into calories?
For idli or dosa or egg, like that.
Do you know the standard method?
It's in the chat, sir.
There is a chart. There is a chart which will tell you. Of course, it is a rough thing because the size of idli in your home and my home may be different. Okay, and there's no standardization. Even chapati, roti, it may be thin and small in one home, and it may be thick and big in another home. So these sort of variables are there, but there's a standardization. Okay, and in fact, I was searching for the standard weight for various Indian dishes like vada, Italy, and all those things. And I was searching the community medicine park book, and then I got a reference. You know, it was interesting to note that the reference is as per Indian Railways. If you go to the Indian Railway restaurant, you will find Italy 50 grams, vada 40 grams, exactly quantified. Okay, so that sort of quantification is not possible. So we will have to approximate according to the approximate intake and come to a calculation. Now you want solve. In this case, it may not be relevant, but in a case with a chronic small bowel diarrhea with malabsorption, and if there is significant weight loss and nutritional deficiency, you will have to tell how much carbohydrate he is taking, how much protein he is taking, how much fat he is taking, and all those things may have to calculate. Okay.
Okay, sir.
Okay, fine.
Benila, there are some discrepancies. When you say he consumes about 1,800 kilocalories, is almost normal.
Yes, sir.
And you have written in your personal history, appetite is normal, and somewhere you have said he has anorexia.
He told it's reduced, but he's taking what he told, sir.
No, but
He
appetite,
doesn't feel to get to be eaten, but because he's losing weight, the family is pushing to
usually
him to eat, and he's
anorexia and
taking.
appetite loss go in hand in hand. Here you said appetite is normal, anorexia. What is the difference between anorexia?
Sir, it's a mistake, sir. Appetite is reduced.
Okay, so beware, because when you write mechanically, these sort of things happen, and examiners will simply catch on that. Okay.
Sorry, sir.
So anything contributing from the past history and personal history?
Diabetes. He's a diabetic. Diabetes and diarrhea. One thing, diabetic diarrhea can occur, but blood and mucus in stools is.
No, do we expect a diabetic diarrhea here?
No, sir.
Then why you are considering that?
Why did you bring diabetic diarrhea now when we are discussing about anorexia, weight loss?
No, sir. It's nothing is contributory, sir.
Yeah, so we have to be extremely careful. Don't blurt out things. Remember that examiners are waiting to pounce upon you. Okay, we are not leopards or anything, but the moment we find an answer which is not according to what is expected of you, we will try to figure it out whether you have said it with a deliberate, whether you really know it, whether it was a mistake, or understand.
Metformin will cause diarrhea?
It can cause drug-induced diarrhea, sir. But blood and mucus diarrhea is unlikely, sir.
Also, how long patient is on metformin?
He's on metformin for the last 5 years. So
and now how will you explain if at all it is due to metformin diarrhea last 2 months only, no?
Yeah, we can't understand, sir.
Most of the GAT side effects of drugs develop within a short period of time, and even liver disease also will occur within usually 90 days of onset of treatment. So after 5 years and all, it will be too far-fetched. Okay, and don't tell anything which is far-fetched. Rule number 1.
Okay, sir.
Because you will not be allowed to present your history even. Okay, you will not reach your syndromic diagnosis. Before that, you will be sort of your discussion will be completely dissected, and your knowledge will be completely assessed, or rather ignorance. Okay.
Rather than telling the vague history, radiation.
Say that word, I hate.
Hello. Rather than telling the vague radiation history, you should specifically ask for a pelvic malignancy and radiation.
Okay,
Because
sir.
radiation somewhere else may not be
Radiation.
more.
This radiation would have been very relevant if the patient was usually which condition you give radiation and patient comes back many years later with blood and mucus, or at least altered bowel habits and blood in stools. The answer
Radiation
is in the chat
colitis.
box.
No, sir is asking which condition causes radiation colitis, for which condition radiation has given.
I gave a clue. If it was a female.
CA endometrium.
Yeah, one of the forms of treatment
It is
for
not endometrium.
Cervix, sir.
CS cervix. Because radiation is one of methods of treatment. Other method is surgery. And in fact, it happens many years later. And they would have completely forgotten about it. Your textbooks of Schlesinger says it can even happen after 25 years. Okay, I have seen it after 15 years, etc. But this can happen many years later. So patient may completely forget that history unless you probe it. Okay. Okay.
Abra?
Sir.
You can proceed.
Family history. There is no history of any tuberculosis or GI malignancies or any Pol-Percy syndrome in the family. Treatment history. He's on metformin 500 mg once daily and atorvastatin 10 mg HS. Socioeconomic history. He's from a upper middle class according to modified Kupusamy scale.
So why you just passingly mentioned GI malignancies or polyposis in the family? What is the relevance?
So one is hereditary syndromes that can predispose to colorectal malignancies.
Like what?
One is FAP, but the age is not one. Attenuated FAP. Then Peutz-Jeghers syndrome, Lynch syndrome, Muir-Torre syndrome. Many other.
In attenuated FAP, where is the malignancy usually?
It can cause lower colonic as well as upper GI malignancies.
No. Colonic where? Is usually right-sided colonic malignancies.
Okay.
So here the presentation is like a distal.
Left.
Even if you are thinking of malignancy, it's a distal
Left side.
colonic malignancy. So even classical FAP as well as attenuated FAP does not come here.
Okay,
Only
sir.
thing which will come, and Peutz-Jeghers is entirely different presentation. Okay. And only thing which you can think of is actually Lynch syndrome.
Yes, sir.
But Lynch syndrome, does it classify here because there is no family history and all?
No family history.
What is the Amsterdam criteria? Okay, probably you are not aware. Read it up. Okay, if you have a case of colorectal malignancy and you have family history and stress it out, they will immediately say, how will you consider this case as Lynch syndrome? Then there's a criteria, no? So you have to follow the criteria. There are old criteria and the new criteria. Both are there. Okay, so you have to.
Asking family history, then IBD family history, Crohn's or ulcerative colitis also need to be asked.
Okay.
Then how will you elicit the family history of malignancy? Just a question of.
So one is any surgeries, any colonoscopy previously and positive finding, or history of any chemotherapy.
First, you have to blatantly ask straight away. Is there any history? Okay. Second, of course, surgery. Then colostomy, and usually colorectal malignancy surgery. Sometimes there may be ostomy bag. Okay. So history, ostomy bag, radiation, chemotherapy. Okay, all those points are well accepted.
Vanilla, if he is a first case of Lynch syndrome, when will you suspect Lynch syndrome in him?
The age of onset is less than 40 years. I mean, age of presentation.
Lynch syndrome, let's say it is less than 50 years. Okay, but here the patient is 52 years.
65 years, sir.
65 years. So it is more likely to be a sporadic carcinoma rather than
a familial or hereditary. Sir.
Have we finished the history? Then we can summarize.
Okay, sir. To summarize, elderly, 65-year-old male with who is a known case of diabetes mellitus and dyslipidemia, without any addictions, presented with chronic large bowel diarrhea mixed with blood and mucus, with a history of significant weight loss, without any features of obstruction, intestinal obstruction or systemic symptoms.
Malabsorption here.
It's
will
a
be
large bowel.
problem.
It's mainly for small bowels. Large bowel malabsorption is
Because if you think of neoplasm, then you have to think of obstruction. Okay, that
Yes, sir.
without any features of
no
obstruction. should
intestinal
be there.
obstruction, sir.
But malabsorption, because you will have problem because you have got chronic large bowel diarrhea,
Yes, sir.
and then if you say malabsorption, you will be minced to pieces. Okay.
Yes, sir. It's more.
So please don't this because even a benign examiner will create problem for you.
Okay, sir.
Because you are diametrically opposite, no? You are
Yes, sir.
committed to chronic large bowel diarrhea, and then you are saying malabsorption. Okay, so that sort of typos should not occur. I consider it as only a typo for the time being.
Thank you, sir.
Including intestinal obstruction. What do you want to convey? Intestinal obstruction, small bowel or large bowel?
Intestinal obstruction can be distal large bowel obstruction. Malignancy can cause large bowel obstruction.
What will be the presentation in large bowel?
It's
Bowel?
abdominal distension.
In this particular patient, what do you think will be the presentation of obstruction? How will you know that there's obstruction in this patient?
One is constipation, ma'am. There is no constipation followed by spurious diarrhea. Maybe, but in this.
So all this you didn't mention it all in the history. So suddenly you say intestinal obstruction is again a whole box, no? The whole GI tract of obstruction, intestinal obstruction starting right from small intestine, large intestine, everything. And
Even spurious diarrhea. For spurious diarrhea to occur, at least for some day, there should be some features of obstruction, but it is partial. It's not that day one it will come with diarrhea and it is spurious. No, that's not the way. Okay.
And
So,
you are mentioning systemic symptoms, you say extra-intestinal manifestation or something like that.
Okay, okay.
What is the systemic symptom that you look for in this patient? Do you mean no obstruction?
already systemic symptom is already there. Giddiness.
It's not, no history of giddiness, sir. No, it's
There is
negative
no history.
Negative, sir. Negative history, sir.
Negative. Okay, so you summarize.
Lot of clarity is required in your presentation, okay? As Dr. D.T. said, even the most benign examiner will get irritated. So just modify your history and improvise on that.
Okay.
Can you rephrase your history?
Small bowel.
All confusion. Exercise. We are making you to say it because it's a teaching clinics. So we want you to tell it properly. That is how you learn. Okay. Don't feel bad about it. Never feel bad about it. We are trying to improve your performance. That's all. Take it that way.
Okay, sir. All small bowel related things we can delete, sir.
No, you can. You don't say you can delete and
So
that would be very detrimental.
So
you mentally delete all the unwanted things from your summary slide and tell it once again.
Okay, sir. History of diarrhea. It's 8 to 10 episodes of
You can use the summary slide. Already summarized. We want the summary to be edited and presented in a better way right now, by eliminating all the unwanted things which we said.
65-year-old male, non-case of diabetes and dyslipidemia, presented with a chronic large bowel bloody diarrhea with mucus, with a history of significant weight loss, without any features of intestinal obstruction.
Okay, or extra-intestinal manifestation or systemic symptom. Okay, so now you have to tell your list of differential diagnosis. You already put it up, no?
Okay, sir. My first possibility is a colorectal malignancy, sir. Either carcinoma or lymphoma.
So when you say your possibility, you have to tell the points in this, or at least 5. Okay.
Okay, sir.
So points in favor and point. Okay, before I think we will call your friends from Chennai, Dr. Dheeraj and Dr. Harish. No, you are there?
Yes, sir.
Do you agree with the differential diagnosis, or do you have any suggestions other than this, or any difference of opinion about the order in which it is given?
Colorectal malignancy, first differential, I agree with it, sir. And
Okay. You will also consider that. Okay.
intestinal tuberculosis, I'll keep as second one.
Why you want to bring in intestinal tuberculosis from 5th position to 2nd position?
Because history of weight loss for within two months.
Okay, but how often you find blood and mucus in intestinal tuberculosis? Because her second diagnosis was ulcerative colitis. Even though weight loss will be difficult to explain, but blood and mucus is much more common than tuberculosis for ulcerative colitis. Okay.
Yes,
In only 15% of cases of tuberculosis, our blood and mucus sort of history is there. It is not a dominant symptom at all for tuberculosis.
yes, sir.
Isolated rectal or isolated left colonic tuberculosis can occur. I won't say it will not happen. I have myself published segmental colonic tuberculosis, but that is a rare thing.
Okay.
And when you say intestinal tuberculosis, you have to say where actually, which part of the intestine is affected, because it can affect from top to bottom. Binila, why this patient has got diarrhea in a colorectal malignancy?
It can be secretory diarrhea, sir, due to inflammatory diarrhea. Due to this growth.
Inflammation due to?
You have to be careful with your words. You can't blurt out things. Inflammatory diarrhea, if you say, one advice I want to tell you, if you don't know the answer, don't feel very bad about it. Say, I do not know. At least we will tell the answer. But never ever say a blunder. Okay, you have already put your colorectal malignancy as a first diagnosis, and Professor Ismail has asked you what is the explanation for the diarrhea in the colorectal malignancy. Okay. Secretory at a far-fetched imagination, I could say if it is a villous adenoma, it can produce secretory diarrhea. Okay. But inflammatory diarrhea, if you say, it will be too difficult for me to accept.
So, villous adenoma, secretory is the presentation is different. It is not like this small volume blood and mucus actually.
Yeah, it is. Secretory is obviously it will be a large volume, no? Even though it may be in the colon, still it will be copious of fluid and lot of mucus, and blood will not be the dominant thing.
They can present with hypokalemia too.
Which are the colonic malignancies which can present with the diarrhea?
One is carcinoids. I mean, neuroendocrine tumors can present with diarrhea.
Okay. Okay, affecting the anywhere. In fact, it is the diarrhea may not be large intestinal at all. Okay.
Yes, sir.
Usually, large intestinal NETs are non-secretory.
Yes, sir.
They won't secrete these active substances to cause diarrhea.
Yes, sir.
Okay, so
Colorectal malignancy is
so you take each part of the colon. Cecum, how does it present?
Cecal malignancy can be usually non-obstructive because of its large size. It's a non-obstructive type. Usually, early it's a non-obstructive. It can progress.
Then how do they? No, my question
It
is
can
that
present with anemia, features of
asked
anemia.
a question, Dr. Binila,
Anemia, sir.
whenever you are asked a question, say positive things first, then followed by negative. My question was that what is the presentation of a neoplasm of the cecum? So there will be some positive findings which they come. Okay. Then if I ask you what is the mechanism, then you have to say there is no obstruction. So first you have to say the symptomatology for the presentation. Then explanation wise you can say the next one. Okay. So that you have to differentiate very clearly. You have to differentiate. Don't mix up issues. Okay. And another thing which I find students creating a problem is that examiners would have thought in a particular line and they want to ask question 1, question 2, question 3. Okay, they will ask question 2 only after they get the answer for question 1. Okay, if you give an answer for question 1, ask for their question 2, either they will stop at that level or you may have problems. Okay. So you are actually given an answer which I was supposed to ask you maybe down the line for third or fourth question. I have not asked that question yet. Okay. So anemia.
Anemia, features of anemia, sir.
Agreed. Anemia is one of the manifestation. Then
It can present as pain in the right lower abdomen.
okay, it can present with abdominal pain, but that is usually unusual because, as you said, cecum is very capacious area, and unless you have a growth which is too big, producing luminal obstruction or strategically producing ileocecal obstruction, features of pain and obstruction will not be there. Okay, but still you can produce altered bowel habits, exaggerated gastrocolic reflex. All those things can happen. Okay. What about the transverse colon? Nothing specific about transverse colon, but the lumen is less. So we can expect luminal symptoms like colonic pain, alteration of bowel habits, and if it is significant obstruction, there may be features of partial obstruction. Left colon, it may be same. What about rectosigmoid?
Blood bleeding per rectum.
Okay.
Constipation. Can be
apart from
experienced.
constipation, in fact, before they develop complete constipation, etc., many people note thinning of the stools. Okay, IBS fellows also will complain of this, but if you have a lot of added symptoms of organic disease, thinning of the stools, which is noted usually, IBS usually is a disease largely of younger age, and they will have long-standing symptoms. This is an elderly person and having normal bowel habits and suddenly saying that my stool has become thinner, and then he has difficulty straining, all those things. Don't think of functional disease, you have to think of organic disease. Okay. And rectum, low rectum?
Can be frequent urgency, frequency of stools, tenesmus, feeling of incomplete evacuation, then digital evacuation, may he use digital evacuation, bleeding per rectum.
Is not that common, okay, but all the other symptoms of rectal involvement can be there. Okay, so it is a colorectal malignancy that can be accepted. Okay, what are the points in favor?
Sir, one is the elderly patient with a significant loss of weight, bleeding rectum, and the duration of symptoms also.
The patient has got a symptoms of colonic disease.
Yes, sir.
Okay, but in fact, if it's a colonic malignancy, what is the symptom of rectal involvement here?
Only not.
Each and every word will be critically analyzed.
Okay, sir.
Okay, I said in the beginning, no, you are not MBBS students. For MBBS student, colorectal malignancy, if they say they will pass. But if you say colorectal malignancy, you will dissect a single diagnosis because you have to differentiate rectum and colon. So what is the symptom of rectal involvement here?
No, nothing.
Nothing.
No,
You have to remember. So you say colonic malignancy.
colonic.
And then we may ask you which side. Then you can say
Left side,
probably
left side.
Maybe we can't. This we cannot definitely say. Can be left-sided. It can be transverse colon also.
Okay.
Ulcerative colitis.
Points in favor are one is large bowel diarrhea with a bleeding per rectum. Against weight loss is not common in ulcerative colitis.
Weight loss is the thing which is very difficult.
And also there is no rectal involvement symptoms like tenesmus, urgency, nothing is there, sir.
Symptoms of rectal involvement are missing. Symptoms of rectal involvement are missing. So that is not there because in 95% of patients they will have rectal symptoms or at least 90%. So that is why perhaps that is why Dr. Dheeraj wanted to bring it down. Okay, that could have been the reason.
The very first thing in IBD is in ulcerative colitis is the frequency. They'll pass 15, 20 times a day, not 3 and 4 per day. That's the first thing. First is the frequency with tenesmus and urgency. If the moment you have a frequency of 2 or 3 per day, it is not IBD. It is not IBD at all. Ulcerative colitis, that's not the presentation. Presentation of ulcerative colitis is every 5 minutes, 10 minutes, they'll keep passing 15, 20 times in acute degree. So this is that is the point that tells you it's not ulcerative colitis. Frequency is the one that determines.
Okay. Why will the frequency so high in ulcerative colitis? What is the reason?
Rectal involvement.
involvement because of
Doctor, I'm not sure, sir.
it's irritating the lower rectum sphincter muscles. It's irritating, and whatever the stool is coming, because of that irritation, patient passing small volume but frequency is so high. So that is not here.
Okay.
Okay, third, IBD Crohn's disease. Here again, Crohn's disease is something which can affect from mouth to anus, no?
Small bowel
Here
involved.
again, you have to be specific.
Yes,
So
sir.
if you are, what was in your mind when you say Crohn's disease?
Large bowel.
So you have to say IBD Crohn's colitis.
Okay, sir.
Okay, you have to put it specifically.
Crohn's colitis.
Okay.
How common is bleeding PR in Crohn's colitis?
It's less common, sir. Frank blood is
No,
less
when
common.
a differential diagnosis is being asked, you need not say 6 or 7 differential diagnoses. You only have to say whichever fits with your history.
Okay, sir.
So, and retroviral disease, opportunistic infection, do you think this?
Bloody diarrhea is less likely, but opportunistic infections like CMV colitis can produce bloody diarrhea. sir.
CMV colitis and all of this will be too symptomatic.
Yeah, yes, sir. Pain will be the bloody diarrhea. Sir.
Systemic symptoms, fever.
Will be the systemic symptoms will be the.
So, blood and mucus diarrhea in a retroviral disease with such of imagination we can explain, but even though it will be put very low in the list. Why there is blood and mucus?
Bloody diarrhea can occur with opportunistic infection, sir, and
Infection. I said very clearly, we are dealing with the DM candidate. You cannot go away with saying broader terms. Which infection? Because opportunistic infection of the colon are many.
yes.
LGV, sir. LGV infection.
Okay, that is not primarily, LGV is not primarily related to HIV infection. A person who is promiscuous can have a sexually transmitted disease and he is doing unprotected sex, can have lymphogranuloma venereum and can have disease of the rectum, and where it can present with ulcers, nodules, and even subsequently stricture. Okay, the same thing can affect females also, and in fact it can affect the vagina also, and they can develop a severe edema, lymphedema of the external genitalia. All those manifestations can occur. Okay, but in a retroviral, I am asking you, when you put retroviral, is there any stretch of imagination or a far-fetched reason for a blood and mucus diarrhea? Okay, one thing is they are more susceptible to ordinary infections also. Okay, like for example, amoebic colitis, it may get prolonged, bacterial colitis, agree. Second, tuberculosis, they can have, but again, blood and mucus, we have already told, is unusual for tuberculosis. But in a patient with a very poor immunity, you can have a purely ulcerated form of tuberculosis. Okay. The classic diarrhea with blood and mucus is extremely unusual in neurological tuberculosis because it's an ulceroconstrictive disease. Okay, pain and altered bowel habits. But in a person with a profound loss of immunity, either due to acquired or otherwise, they may develop extensive ulcerations of the bowel, and in which case they can present with diarrhea as a dominant manifestation, weight loss as an important manifestation, and some blood in the stools. There again, a classic blood and mucus diarrhea like in a dysentery is very unusual. Okay. Then Kaposi sarcoma, can you present with the blood and mucus?
Can present with blood in stools, sir, mucus.
Mucus is just addition for everything. Okay, so you must be able to defend. See, use of retroviral disease, opportunistic infections. You should be ready for the answers. What all things are likely to produce? Okay. What is the most common opportunistic infection which occurs over the GI tract, which occurs in HIV disease?
Cyclosporidium, isospora.
So many of these will produce watery diarrhea.
Small bowel diarrhea.
Usually unusual.
Yes, sir.
CMV.
CMV colitis can produce,
okay.
blood.
But there again, bloody stools can occur, but the patient will be extremely sick, you know. What about mycobacterium, AVM complex? It can produce disease of the small as well as large
Large
intestine.
bowel.
Okay. So that can produce again diarrhea and all this manifestation. So even though a classic blood and mucus again may not be that very typical, but in every disease up to 15 to 20%, if you look at the literature, some blood and mucus may be described. But whenever you harp on a rare manifestation of a common disease, you are likely to be wrong. That is the rule. Okay. When you harp on a rare manifestation of a common disease and try to put it as a prominent diagnosis, your statistical chance of being wrong will be higher. Common things, common. That's it.
Okay.
To other faculty, she has put the ischemic colitis. What's your comment about it, Professor Ismail?
When you say ischemic colitis, whether it is acute or chronic?
Usually acute, sir.
Acute, is it the
No,
presentation?
sir. Abdominal
They will
pain
have
is
severe
the
abdominal pain.
abdominal pain is the most common.
So is it chronic?
That can produce postprandial abdominal pain, sir. Abdominal pain is absent in this case.
Postprandial abdominal pain, small bowel angina, small intestinal angina. Okay. And first and foremost, rectal ischemia is extremely rare. The rectosigmoid or left colon is the one area where it happens rarely in very elderly people. And acutely, it can produce pain, bleeding, etc. Chronically, stricture and constipation.
Okay.
That will be the manifestation, not blood and mucus diarrhea. Okay.
Could it be diverticulitis?
Weight loss is unlikely in diverticulitis, sir. Profuse bleeding can occur with the.
Can colitis occur in diverticulosis?
Yes, sir.
What is SCAD?
I'm not sure, sir.
Segmental colitis associated with the diverticular disease. That is an entity which is increasingly recognized. Professor Ismail, can you just tell us about that? I know you know more about it.
It is basically like IBD. You will have inflammation around the diverticula. So it can present like ulcerative colitis, but only thing is that it is around the diverticular pouches where you get this. You take biopsies, it will show inflammation of the colon. Segmental colitis associated with diverticular disease.
Okay. You may ask in Viva also what is this entity. Okay, if all the faculty are agreeable, can we proceed further? And we will ask our discussion from Chennai. Do you have any other differential diagnosis? Do you think anything else to be considered?
Yes or yes?
Dr. Dheeraj first, followed by Dr. Harish.
Yes or yes?
Okay, that is one good point. But what is the dominant symptom in SRUS?
Digital evacuation and constipation.
Difficulty in evacuation or constipation comes under one of the symptomatology of constipation. No? Difficulty is training at stools, digital evacuation, all those things will be there. No? And a classic diarrhea with blood and mucus will be unusual. If somebody has perhaps difficulty in evacuation plus digital evacuation plus some blood, some mucus. Mucus, of course, they can have copious mucus. SRU, they can have copious mucus, a little bit of blood, but the dominant symptom will not be diarrhea. But good that you thought about it. Okay.
Villus adenoma?
Villus polyp.
Can it be a villus adenoma?
Yes, ma'am.
What are your differentials? No?
Can in case of a large colorectal polyp or
A large one.
Differential. These are the differentials, and you should not put IBD and all these up.
Okay, can we proceed further? Okay, physical examination, Dr. Binila.
Patient is conscious, cooperative, moderately built and nourished. Height is 162, weight is 64 kilogram, and BMI is 24. There is no pallor, no icterus, no cyanosis, no clubbing, no edema or generalized or no other lymphadenopathy. Pulse rate is 68 per minute, regular and normal volume. Blood pressure is normal. Respiratory rate is normal. He is afebrile. Examination of oral cavity. There is no oral thrush. Teeth is normal. Tonsils were normal. There is no oral ulcers. No hyperpigmentation. Skin is normal. There is no rash, telangiectasia, ulcers or patches.
Dr. Binila, again. Dr. Vinila, you have said so many no's. The
Yes,
no's
sir.
must be relevant to the case, relevant to the gist of differential diagnosis.
Yes, sir.
Okay.
Or thrush, because HIV is one of my diagnosis
Okay.
possibility. Then cheilitis, mainly to malabsorption, sir.
We
Hyperpigmentation,
are not
sir.
bringing up malabsorption.
Yes, sir.
Okay, don't
Then
bring it again.
hyperpigmentation,
Dr.
food sugar
Vinita,
syndrome, and
one
all,
minute.
sir.
What is the most important thing that you look for a colorectal cancer? What are the cutaneous markers you look for? Just hang on to that.
No cutaneous markers of external malignancy, like there is no acanthosis nigricans, no dryness of skin.
Acanthosis nigricans in lower GI. What do you look for colorectal malignancy? Polyps. What are the cutaneous markers of polyposis? Supposing I
It's a
say
direct question. What are the manifestation of Gardner syndrome?
Gardner syndrome, polyposis, this bronchi candida syndrome.
What you palpate in the head for?
Sir?
You palpate the head of the patient for what?
Osteomas.
Yes,
Sir.
osteomas. Then skin, subcutaneous tissue, fibromas.
Fibromas, sir.
Okay.
The
So this
mouth, supernumerary teeth,
Hyperpigmentation.
supernumerary teeth.
It's a supernumerary teeth. Hyperpigmentation.
okay.
Don't, this, I do not know how to tell you. You cannot write hair normal, nail normal. This is not the way to describe at all. This is not the way to present. To improvise. Why did you look for the fundus?
Sir, he's a diabetic, ma'am.
Only that? Any other?
FAP, what will you see?
FAP, what will you see? I thought you were looking into that and not for diabetes retinopathy. And you know what you will ask? Doctor, what are the findings in diabetic retinopathy? They'll go towards that. The whole discussion will go elsewhere.
I'm not sure about FAP findings. Fundus findings in
Eyes, you mentioned pigmentation. What pigmentation in eyes? What is the pigmentation in eyes?
Sort of a fundal pigmentation and probably typed it earlier and okay. But each and every word I told you, will be critically evaluated. Okay.
Okay.
What skin ulcers did you look for? Skin ulcers, ecchymotic patches. What are all these? Ulcer?
IBD is one of my differential, ma'am.
Okay. Then listen. I am going to ask you the typical question. You put skin, no rash. What is the rash you expect in this patient?
Either erythema
It was in your
nodosa.
mind. You must be very fast. You thought of something, no? You look for it. What was you looking for it?
Erythema nodosum.
Then you have to say erythema nodosum. Okay. Then?
Telangiectasia for
Why telangiectasia?
Osler-Weber-Rendu syndrome, sir.
But this is not sort of pakka bleeding PR, no?
Yes, sir.
That is for a person coming with anemia or a person present with recurrent melena or etc. etc. No, this is a case of blood and mucus.
Yes, sir.
That was, we did not consider Osler-Weber-Rendu syndrome in our differential diagnosis. Ulcers. So where are pyoderma? Okay, you can say not erythema nodosum, no pyoderma. Okay. Ecchymotic patches.
So maybe to vitamin E deficiency.
Why vitamin K deficiency?
Less like small bowel.
Okay, fine. Because we eliminated small bowel. Then acanthosis.
It's a cutaneous marker of malignancy as well as insulin resistance, type 2 diabetes.
Type 2 diabetes. But he is not again, he has lost weight, no? Okay, dryness of skin.
Ichthyosis can be a manifestation of cutaneous marker of indel malignancy.
But then you have to say ichthyosis. But there again, it is not the manifestation of colonic disease, no?
Yes, sir.
Okay. Then don't put vague things like dryness of the skin, etc. If you have some specific points, put it. Okay. You can say no cutaneous markers of malignancy like 1, 2, 3, 4, which is specific for colonic disease. After having discussed colonic disease, you cannot go and discuss the gastric, pancreatic, or bronchial, etc. Okay. So that has to be.
What is your reference regarding ichthyosis as skin manifestation of internal malignancy? Yeah, you may be right. I don't know. That's why I am asking.
In some books, it is mentioned as internal malignancy.
Dermat
Late
books. During
onset.
my undergraduate, I
Yeah.
remember seeing.
Ichthyosis by and large is
First edition.
from birth, but if they have a late onset of ichthyosis, I have not read it in books, but I have heard seniors telling it.
Okay, sir.
Okay, hair.
Okay, go ahead.
Okay, sir. Abdominal
Okay,
examination.
hair, Vanilla. This
Yes, sir.
hair description is required in a small bowel diarrhea with a malabsorption.
Yes,
Okay, similarly, in a patient with either chronic anemia or a small bowel disease, malabsorption, nail changes may be there. Okay, so you thought of discussing small bowel and large bowel together. That is all this confusion. We wanted specifically a discussion on the large bowel with
bowel,
specific blood and mucus. Okay.
Okay.
So we wanted to have the discussion pointed to only to the particular differential diagnosis.
Okay.
You are doing for diarrhea. That is, that is for when I teach you, I will tell all these things. Okay, manifestations of diarrhea, cutaneous manifestations of chronic small bowel diarrhea, etc. But in your case, you cannot repeat it. In your case, it has to be specific for your case.
Okay.
That is the difference. Okay.
Okay, sir.
Okay, examination of abdomen.
Abdomen is scaphoid. Umbilicus is central and inverted. All areas moves equally with respiratory. No visible swellings. There is no scars, no sinus or dilated veins. No visible pulsations or peristalsis. External genitalia and hernial orifice are normal. Abdomen is non-tender on palpation. No palpable organomegaly. Liver span is 12 centimeter and there is no shifting dullness. Trough space is resonant. Bowel sounds are heard normally. For rectal examination, there is no fissures, fistulas. Sphincter tone is normal and normal fecal staining present. And no mass or irregularity felt on the rectal examination. Proctoscopy is normal mucosa sensor.
So after physical examination, how you become wiser?
What are the important things you look for on examination of the abdomen in this particular patient? What's your focus of attention?
One is any features of intestinal obstruction, ma'am. Large bowel obstruction.
How do you detect large bowel obstruction examination? What are the important things?
What is the most important thing you would like to know? Your first diagnosis of malignancy. So in a malignancy, you will search for thing in the abdomen. Lump.
Lumps, no lump palpable, no
Lump abdomen. Okay, that is the first thing you will look for. Second thing, you are interested to know the liver is enlarged. Secondaries.
No, sir, okay. It's not enlarged.
Okay, third thing, whether ascites is there.
It's not there, sir.
Okay.
1 minute. See, you're just accepting what you're saying. We're asking you a very specific question. In this patient who comes to you bleeding for rectum, what are the things that crosses your mind you should examine? What are the things that cross your mind? What is it? What you should look for? Left iliac fossa. Look for a mass. Look for a gurgle. Look for palpable fecal masses. These are the things that you look for. Palpate a lump. Very often a splenic flexure mass will be just palpable like a spleen.
Okay.
And we've seen all these types of cases. So your focus of attention, you see this patient is, and a good detailed rectal examination. That's all that you need. And a liver that is palpable or not palpable. Why do you want to check the liver?
One is liver metastasis, ma'am.
How will it present? Large lumps, is it? What is the presentation of secondaries due to colorectal malignancy? What will be the size? What do you expect the liver to be enlarged?
Usually no, sir. Multiple small.
I never use the word no palpable organomegaly. Okay, there's nothing like that.
Okay.
No palpable organomegaly. I don't know where you got all these terminologies. Palpable organomegaly. So liver, they're all small metastatic lesion, 2 centimeter, 3 centimeter. That's it.
Okay.
And you look for a local gurgle. Focus here. When you see the patient in OP, your first direction will be quickly look for the liver. Go straight, see that you don't miss a spleen vis-a-vis a mass rising from the splenic flexure, which can be present as a nodular mass. Most important is a mass in left iliac. What are the components of a likelihood of a mass in the left iliac fossa? This is a common question. What are the components of this mass in the left iliac fossa? If you have a mass in the left iliac fossa, what are its components? What are the components of the mass?
Can be descending colon?
No. Vanilla, I think you do not understand the question. When you have got a mass, we are diagnosis is neoplasm. Okay. So the question is that what are the structures which make up the mass? Suppose you have cross section and look at it.
Dheeraj? What are the components of the mass, Dheeraj? Harish, Dheeraj?
Ma'am, bowel, including mesentery.
Okay, bowel mass, you are meaning there is a neoplasm as such. Okay.
Lymphadenopathy can be, lymph node mass can be enlarged.
Good.
Fecal mass. You can palpate feces. So how will you differentiate a fecal mass from a growth? Indentation. So fecal mass will have indentation. You can dip your finger, whereas a hard mass will not. All these are common questions that are asked in the exam. So the components would be the mesentery that's attached to it, sigmoid, then you can have the mass per se. It may find actually a fecal mass that is palpable, nodal masses that are around mesentery. These are the components of the mass. So that is what you could describe in this patient. Focus your attention only to that, and not to say no palpable organomegaly. So what did you look for in rectal examination, doctor?
Ma'am, one is any fissures or fistula.
What are you looking for in this particular patient? What is your focus of attention in this patient?
Any
This patient is a male patient. What's the age of the patient?
65 prostate, ma'am.
What? So have you mentioned that?
No, mass or anterior rectal wall. There can be prominence or irregularity felt if there is a.
Not anything about prostate, no? One is a growth. Any growth? What else would you look for in this patient? One is a growth, number one. Number two? What are the other things that you look for? Prostate enlarged. How would you know the prostate is enlarged? By rectal examination? The disappearance of the indentation. Normally you'll find that there's an indentation between the lobes. But here, once that is lost, that means there's almost a suspected prostatic enlargement. And look for all the pouches so that you don't miss any of the deposits there. And most important, focus your attention towards the stricture, and everything depends on what is the length of the anal canal and what is the length of the anal canal, and this because it depends on the index finger, your index finger length. That will tell you whether one other person may just pick up the mass, you may not have picked up the mass.
3 to 4 centimeters.
Anal canal will be 3 to 5 centimeters, and rectum is 10 to 12.
Yes.
All these questions are asked, doctor. The DNB exam, especially, you just ask all these questions. Okay, carry on.
Okay. I think from other systems are also normal. So we have not got any new findings. Therefore, we have to investigate. We'll ask Dr. Dheeraj to plan the investigations.
Level 1 investigation. I think you can go straight.
Okay. Don't show the investigation. Let him plan and then show the investigation. And after that, he will interpret the investigation. Okay.
I will ask for a complete blood count to quantify the anemia as the patient is passing blood in stools, and liver function tests to see for any LFT abnormalities to rule out liver mets, and
Abnormality you expect?
any elevation in bilirubin, ALP elevation.
So you specific, suppose this patient has no jaundice clinically,
Yes,
history-wise or examination-wise. So you don't expect bilirubin.
yes,
So I just one investigation result of LFT.
alkaline phosphatase, sir.
Yes, alphos, if it is elevated, you have to be careful. Okay.
Yes,
How common is bilirubin elevated in metastasis?
How common?
Is jaundice a manifestation, the usual manifestation of liver mets of colorectal malignancy?
No, sir.
No, not unless it is extremely advanced and their liver is
Advanced
affected,
stage.
jaundice will not happen. No, so the jaundice is not.
Or if there are nodes at the high level.
Yes.
Yes, obstructive jaundice happening. Okay, you said LFT, fine. Next.
Tumor markers of colorectal malignancy, CEA.
What is the role of tumor markers for the diagnosis?
for prognostication purpose, it will be useful.
No, no, no.
Not-
We are
You are
now
going to-
okay. First, we
We are-
have to investigate to diagnose, no?
Yes.
Okay, in such situations, anyway, we will be all doing routine tests. So one way of saving time, apart from the routine test, I will be doing the following. Okay, among the routine tests, I will be interested to know the hemoglobin level as well as in the LFT, the alkaline phosphatase level. Creatine also I will be interested because I will be planning a cross-sectional imaging, especially CT. Okay,
Yes.
that is what I would say. And then go for the next line of investigation, specific ones.
CEA ones are specific ones.
CA, we told me it's not for use for
No.
for the immediate. If we find the diagnosis on the next investigation as CA rectum, for the prognosis part, we will be using it. But we have not yet diagnosed CA rectum, no, or CA colon. Blood and mucus. What is the next investigation you want?
Stool routine.
Okay.
What do you do in by stool routine?
In stool routine, we will.
Okay, what do you want to know in stool routine to make a differential diagnosis? What is the value of a stool protein in this case?
Stool calprotectin will for IBD.
That is not stool protein.
Yes.
That is not stool protein. Second, when there is obviously blood, there is no role for calprotectin, no?
Yes.
See, calprotectin is done when you have got a disease where you have no clue, and especially of the small bowel, when you have no idea, you cannot find it out, then you find out whether there is a mucosal damage and shedding of leukocytes. Okay, so calprotectin is the end product of that. So in a patient with blood and mucus, we have already a syndromic diagnosis of colon, and we have put a diagnosis of either inflammatory bowel disease or colorectal neoplasm. Colorectal neoplasm as first and inflammatory bowel disease as second, and few others later. So what is the test now you want to do to confirm it? Okay, you said stool examination. We will not find fault with you for telling stool examination, but what do you expect on a stool examination? In a CA rectum, what do you expect?
Nothing.
Dr. Harish?
Sir, in this patient, chronic infections, amoebiasis.
Amoebiasis, chronic amoebiasis is something which nobody is very happy. Okay, amoebiasis is still considered an acute infection, and the so-called chronic amoebiasis does not present at all with blood and mucus. Okay, amoeboma and mucus. Okay, so if it is a little shorter history, like less than 2 months, you would entertain and look for RBCs, pus cells, and presence of EH. How will you diagnose EH trophozoite?
Usually, RBC will be seen within the.
So to see EH trophozoite, what is the precaution you have to take? The usual habit of patients are to collect feces from home, bring it in the container and give it to the lab. And they will leisurely do it after 2-3 hours. And even if amoeba is there, it will be dead. Okay. So fresh stools. Immediately produce the fresh stools, or you can do a rectal examination without contamination and then take and smear it on a slide and put saline. Okay. So erythrophagocytosis, that is EH trophocytes are actively motile. Okay, and unless you have seen it once or seen the picture, it will be difficult. I may tell something you may understand, but there should be RBCs inside the trophocyte. That is evidence of that is its aggression. Because you may find trophocytes which are without any RBCs. It does not mean that it is amoebiasis. Because a person with amoebic carrier state may develop acute diarrhea and they may produce EH trophocyte. Okay, it doesn't mean that it is amoebic colitis. So RBCs have to be there for amoebic colitis. Okay, then in an IBD patient, there can be a lot of pus cells and RBCs. Okay, so stool examination has a value, But in a person with obvious blood in the stool, there's no point in going doing stool occult blood and all. Okay, because obviously there is blood in the stool, so there's no big point in doing stool occult blood. So people tell these answers in the examination and then have problems. Okay, we finished stool examination. Next.
I would like to do a colonoscopy, sigmoidoscopy, or a
Or rather do colonoscopy because
synchronously.
disease is still further and for a complete evaluation. Do you suppose the disease is confined to the rectum? Okay, on a rectal examination, you could actually feel it. So will we be happy with the sigmoidoscopy?
Will complete colonoscopy is required to see
What is the
synchronous.
need? What is the need? Okay, synchronous
Synchronous.
malignancy. Okay, how often you get synchronous malignancy?
Oh.
The two types are synchronous and metachronous. You have to read it. Okay, there should be some homework. And one is to find out the synchronous malignancy. Second is, of course, if there are small polyps, you have to assess the extent of polyposis. There may be other polyps, bigger ones, etc., etc. Okay. Professor Ismail, anything else?
No, sir.
Okay, so now we will show, and of course, then if a neoplasm is found, we have to do further imaging as well. Okay. Which imaging you should, suppose there's a rectal neoplasm, which imaging you want to do?
Staging of the, we need to know the involvement of the bowel wall. So either an MRI pelvis
MRI or a CT. Okay.
or a EUS rectal ultrasound.
Okay, but EUS will only show the local involvement. We would rather to like to get the local extension plus liver extension and perhaps lung also if you want to do surgery. And okay, all those things. Okay, we will look at the investigations available. Dr. Dheeraj, please look at the investigation.
Yeah, hemoglobin 13.7.
Okay, we will go fast. We have only little time. So look at
CA is 3.6 and ESR is 72. Rest all normal. ALP is not. ALP is not mentioned.
Okay, the only thing which wanted is not there. Okay,
ALB, it's mentioned as ALP. It's a.
Oh, okay, fine. What did you say? Which is TP?
Alkaline.
That is albumin only.
Albumin, that is.
Vanilla, again, don't land in trouble because this is 4.2. Okay, this is TP, albumin, AG. So it comes in between. So I will watch that it is albumin only and it is 4.2. Nowhere in the world I have seen alkaline phosphatase such low except in King Angstrom unit, which is 3 to 13 normal, and that is not used by anybody. Everyone uses IU, no? So don't create an impression that you are quite capable of giving any answer at any moment. Okay. Once the examiner gets that sort of an impression, you actually will be in trouble. I am not casting any aspersions on you, but beware. Each and every of your action will be critically evaluated. Okay, next slide.
Stool routine, semi-formed, blood is present, WBC 2
okay,
to 3.
RBC is present. Next.
Just move forward. Yeah.
Colonoscopy, circumferential growth seen in the upper rectum, 7 centimeters from the anal verge, biopsy taken. Scope could not be negotiated beyond the growth.
Okay, next.
You think this is being missed in the rectal examination?
Yes, ma'am. Proctoscopy, there is
7 centimeter, 7 centimeter.
7 centimeter, you cannot miss, no? You cannot miss a 7 centimeter growth on rectal examination.
Proctoscopy is given as normal in the examination.
At least get blood on the finger stall. No?
Okay.
It's not possible. So
the MRI pelvis, bowel wall thickening is noted in the rectum and sigmoid.
What would you do in the colonoscopy? What is important? Could you pass through that? Could they pass through it and go further beyond?
The attempted course could not be negotiated beyond the growth.
So what would you? First is the histology, no? Then only you go for the rest of it.
Biopsy.
Dr. Benila, what is the biopsy like?
Huh?
What is the histopathology?
It's adenocarcinoma, well differentiated adenocarcinoma.
Adenocarcinoma. Okay, so it's a neoplasm. So
staging of the disease now. That's all.
okay. So next imaging, please.
What are the various staging radiological evaluations you want in this patient?
Ma'am, MRI pelvis.
Let them answer, Harish and
We have to
change this disease.
ma'am, we have to see the any lymph nodal metastasis or a distant metastasis. For that, we need both CCT abdomen along with chest CT to look for any metastasis in the liver, lymph nodes, or even in the lungs.
If you want to look for metastasis, will you go for CT or will you go for PET scan?
CT is sufficient.
Suppose you see a nodule in the lung, how sure are you that it's?
If it is a hyper-enhancing nodule, we can consider it as metastasis.
But inflammatory disease like tuberculosis also can create problems, no?
Yes, sir.
Okay. So you have to know about the staging of the local staging, and there are different types of staging. What are the staging for sphere rectum?
TNM classification.
Okay. So you will assess it, and then how will you assess the operability of a person?
Based on the stage 2, 3, surgery is the mainstay of treatment.
So before surgery, first you have to, for this particular patient, you have to comorbidities are only diabetes, but you have to assess for comorbidities, assess for the performance status, then discuss with them their willingness, because it is not just removal, because you have to tell the options of colostomy bag, so many things will have to be discussed, no?
Yes, sir.
And even on opening, it could turn out to be a palliative surgery, because you think of a radical resection, and on opening you find nodules in the peritoneum, and then you convert it into palliative surgery. So every aspect will have to be discussed with the patient and relatives, and then you proceed with the surgery. Okay.
Dheeraj, why do you want two imaging? Why do you want MR pelvis?
MR pelvis.
Why not
so
CT alone? CT alone, which can see the liver, everything.
MRI pelvis, we can see the extent of the lesion, whether it is crossing the serosa or not.
Local extent of the
Local
disease.
extension.
So why is it important here?
What is the most important thing you're looking for? Mesorectal fascia. That's what
Yes.
you're looking for. Why is it important?
Once
Tell.
mesorectal fascia is involved, chance of metastasis will be very high, like distant metastasis, like to lymph nodes.
No.
Recurrence following surgery will be high.
Yeah, local recurrence, basically.
Local recurrence.
The most important is whether you can do the excision along with the mesorectal fascia or not. That is what is most important.
It's called TME, no? Total mesorectal excision.
Total mesorectal incision. That's most important. And just like you have your CVARS classification in the upper portion, you have again lower rectal, mid rectum, and proximal. So the treatment will become either neoadjuvant chemo, radiation, and then radiation followed by surgery. Adjuvant chemo. All these things are the ones that will require complete discussion. Low rectum will have a different connotation of treatment versus a person who's got upper third, which will behave more like a sigmoid, just like in esophagus. So it's just the reverse. Just like you have the CVARS classification there, upper, middle, and lower, junctional, you have just the same here. You have at the rectal, at the sphincter, just below and just above. The upper one will behave like a sigmoid growth. Whereas the middle and the lower one will behave like a growth which requires a upfront radiation and then followed by chemo and then maybe surgery in between. That requires extensive discussion. Maybe someone can give us a talk on management of CA rectum.
Yeah, I think because we seldom go to the depths of that.
That's what.
We
But
have to.
it's good to know that. So you can ask someone to give a talk on that. Management of CA rectum.
We'll ask one of the surgical gastro people to cover it one of these days. Okay. Any more slides, Dr. Binila?
MRI pelvis report is it's a asymmetrical thickening. It's a distal anal wall to distal tumor margin is 13.2 centimeter on MRI, and its extramural depth is 6.5 mm. So it's a T3, sir, with a few extra mesorectal and pericolonic lymph nodes, mainly in the left internal iliac. So 2 notes are there. CT chest and abdomen was done. CT chest, abdomen showing rectal mass. Then lung, CT chest shows a peripherally enhancing nodule in the left lung. So there is a clear rectum with a lung mets. There is also there is a suspicious eccentric wall thickening in the splenic fracture of colon. We cannot complete colonoscopy since we cannot negotiate the scope beyond the growth. And also there is a probable metastasis in the left lung.
How would you manage this patient?
Yes.
How will you manage this patient? Extensive metastasis. How will you release
Since lung metastasis
just tell how you
with
manage 1, 2, 3.
with lymph nodes, so a neoadjuvant approach can be followed first.
Come on, yeah, you have to relieve his obstruction, no? That's all. This advanced malignancy, no? What is your Fox and Falconi regimen? Those are advanced carcinomas, no?
Yes, ma'am. But even in advanced malignancy,
obstruction.
we'll go with a SEMS placement.
Okay, for obstruction. Okay, now another question, Dr. Dheeraj. This patient doesn't have liver mets, but possibly a lung metastasis there. So usually when there's a lung met or a liver met in other carcinoma, we consider it as inoperable or a radical treatment is not possible. What is the difference between colorectal malignancy and other malignancy regarding management when there is liver mets and lung mets?
In liver mets and lung mets, first we will give a trial of chemotherapy. If the metastatic tumor is responding to chemotherapy, we can proceed with surgery of the even metastatic one and also primary tumor. If
it also depends upon the number of metastases, which lobes, whether it's bilobe or single lobe.
Yes, sir.
So there are a lot of things which are involved. You cannot just go for metastatic.
Yes, sir.
So metastasectomy is dependent on the number and extent. Not everything. Suppose it is bilateral extensive in the lung, it is impossible.
Inoperable, yes, sir.
Okay, so it depends upon the number and extent. That's the important thing. But so isolated few is not a contraindication for a radical surgery. That one should remember. Okay. So metastasectomy is possible even in such situations, in selected situations. Okay, further comments, any further slides?
Yes, sir.
You operated any details?
Sir, he started on neoadjuvant chemotherapy with 5FU, glucoverin, and we are planning for a PET scan after the chemo and planning for resection with if there is metastasis up to 3 from lung and 4 mets in the liver can also be excised. In his case, there is no liver mets, and we are planning for a PET after the neoadjuvant chemo and planning surgery. And he is symptomatically better now with the chemo, neoadjuvant chemo, sir.
Okay. Okay, thank you, Dr. Vinila, for the presentation. And can the faculty, Jayanti ma'am and Professor Ismail, please sum up points to learn, things to be stressed in such case?
Madam, you are muted. Madam, you are muted.
Important is, I think, first and foremost in the history taking. I think that's most important. Just think you're sitting in the OP, even in the examination hall, that you're sitting in the OP and just taking a regular history. Focus only on the patient and don't get diverted with the entire GI involvement like the way we discussed today. I think it's good that you presented a patient with this type of presentation so everyone is aware that this is not the way to present. We've learned a lot from your presentation. And likewise, examination will be focused only to what you're thinking, what your mind thinks only you'll see. If your mind does not think of anything, you're not going to see it also. So once you know to see it, then you have to focus on left gap fossa immediately. Can there be a splenic flexure mass? Just see that. I mentioned that, and look, there is a mass there. You remember, I just mentioned that you must see, don't miss a splenic flexure growth because it will just felt like a spleen. And this patient does have a mass another lesion in the splenic flexure. So unless your mind knows what you're thinking, so I think today's presentation is largely focused on the history taking. It's actually just a short case. And I still feel that the rectal examination has been missed. Be very careful. If the candidate ahead of you has picked up the growth and you missed it, that means you have missed the finding, because there's no other investigation required. No physical examination itself tells you that there's a growth, and there's no investigation required. Once you find a growth in rectal examination, the next will be only staging the disease, getting colonoscopy done and staging the disease. And other investigations are for management, like hemoglobin is low, then you pick up on that. So the rest of it is on surgery, diabetes control, ECG to be taken. Those are the other things that side. But if rectal examination has missed the finding, that is the worst mistake that any person can do during the examination. Because I feel 7 centimeter growth should have been picked up. Bend the knees, bend the thighs nicely, and try your best to pick up the growth as much as possible.
Ismail?
Same as Madam said, you have to concentrate on the presenting complaints of the patient and try to elaborate on it rather than bringing all the negative points. Second is, when you are giving a differential diagnosis, give only 1 or 2 or 3 differential diagnoses rather than putting more differential diagnoses and creating more problems for yourself. So stick on to a few things.
Dr. Ramesh,
yeah. When a patient is saying some history, planned history with a chief complaint early around him, because if patient is saying loose motion, ask relevant question. Bleeding be a relevant question rather than saying everything. And the physical examination also, first you have to make in mind that these are the things I am going to look, and look for those things initially. Because mass need to be mentioned this type of case.
Okay, so read. I want to tell you that you have to read around the case. Okay. Now the first diagnosis, the differential diagnosis, all those things. Okay. If you put tuberculosis, the first question will be asked is how often you get, but how many percentage of patient with the tuberculosis have blood and mucus or bleeding PR? That's the immediate question you will get. Okay. And once you said Crohn's colitis, Professor Ismail asked, no, how many percentage of patients present with bleeding PR? Okay. So this you have to be up to date from the literature. Okay, and especially if the cases sort of pertaining to India, like tuberculosis, if there are Indian studies, you must be able to quote some Indian studies as well. Okay, some important Indian studies. Professor Ismail, you actually I interrupted you. Is there anything which you want to continue?
No, sir.
For GI tuberculosis, just remember PWD, pain, weight loss, and diarrhea. Classic symptoms.
Yeah, it is in all classic cases in Crohn's and tuberculosis for practical purpose. Must be there where you have tuberculosis without abdominal pain, with only a diarrhea. Okay. So can we close the session? Dr. Srividya, for the formalities, are you there?
Yes, sir. Yes, sir.
Okay. For vote of thanks.
Respected teachers and friends, I extend my sincere gratitude to Dr. Ismail sir and Dr. Ramesh sir for an excellent discussion. I would also extend my wholehearted thanks to Jayanti madam and Varghese sir for giving very informative session. And also, I would like to thank Dr. Binila, Dheeraj and Harish for their participation. And also, I'd like to thank Sun Sickness for their support. Thank you all once again for your valuable participation. Thank you.
Thank you. Next will be next Thursday, no ma'am? Next Thursday. Okay.
30th, no? 30th.
This week you have clinics, no? Chennai, SRMC?
SRMC is on Friday.
This Friday, 24th, no?
Yeah.
24th, 2:30, no?
2 p.m. 2 p.m.
2 p.m. Okay.
2 to 3. Dr. Epen is giving a talk 2 to 2:20, and then one case presentation on non-necrotic intrahepatic. I'll get the slides today.
Okay. Okay. So try to attend as many clinics as possible. Okay.
And
clinics is the one in the examination.
30th will be the clinics.
Okay. Thank you all. Thank you all. Good night to all of you. We'll close the session. Good night. Thank you. Thank you again.
Thank you.